buonasera.
Ciao, ciao Yorgos, ciao.
Sono felice di vederti in good health. So
Well,
let's
in
start.
better health.
Let's start. Professor Cecchi is the pioneer in hypertrophic cardiomyopathy. As I told before, Franco is the man who inspired me in cardiomyopathies. So we are a little late, so we should move on. First, I would like to call Despina Parcharidou for a very brief presentation, and then Franco Cecchi will discuss a very, very crucial issue, the use of myosin inhibitors in hypertrophic obstructive cardiomyopathy.
So I will show only some basic things and of our patients, our basic data in 5 minutes, very quickly. The first patient is a female, 62-year-old. The reason for diagnosis was incidental finding of murmur and angina-like symptoms in 2007. She's in functional class 2. She has no syncope. And this letter that you see is a letter for Professor McKenna to Professor Efthimiadis for the patient about the consultation that she did to the patient back in 2007. And so we discussed, and together with Professor McKenna, and we decided to give this patient the mavacamten. You can see that she has severe MR, and her gradient is of 75 millimeters per mercury. So after 9 months of therapy on mavacamten, you can see that the MR is reduced, and also there is no gradient at rest anymore. The second patient is a female, 44-year-old. She had a mitral valve repair in 2016 due to severe MR, some related, and in 2018 she had a redo because again due to MR, and in 2022 she has severe MR again. She's in functional class 2 and she doesn't want to do a new operation. So we decided off-label to give her a chance with mavacamten. Here you can see the sum and also the severe MR and the gradient of 92 millimeters per mercury. So after 9 months therapy with mavacamten, you can see that the MR is still there and the resting gradient is 51 millimeters per mercury. The third patient, The third patient is a male, 75-year-old. The reason for diagnosis was angina. He is in functional class 3 and he has moderate aortic stenosis. Here you can see the echo, you can see the sum and the hypertrophy and the aortic stenosis. He has a gradient of 75 millimeters per mercury and he has significant MR. So after 3 months of therapy, you can see that the sum is incomplete and the gradient is only 12 millimeters per mercury. And so he had a great response to the drug. Here you see some of the data of our 5 patients that we have. We have 2 patients that they finished their 9-month therapy, and two more patients, they finished the 6-month therapy, and 1 patient that finished the 1-month therapy. And you can see the graph of the peak gradients. All of our patients, they administered gradients, and the greatest reduction was in the first month. And here you can see a graph of the NT-proBNP, and again, all of our patients reduced their NT-proBNP. You can see that the patient 2 had an increase in NT-proBNP between the 2 and the 3rd month, the 2nd and the 3rd month of therapy, and that was because she couldn't take the drug from the AOP, from the national organization about the drug. So that was all for me. And Professor Cecchi, the floor is yours.
Thank you. Thank you, Despina. Franco, have you any comment on Despina's
Well,
results?
yeah, it was. I mean, I was a little bit surprised about the fact that also the mitral regurgitation. I mean, almost went over. I mean, in several patients. So it's not only the gradient, but also the mitral regurgitation. I was puzzled by the aortic stenosis. If I understood correctly, there is a patient that aortic stenosis. Is it correct?
Yes, yes.
Άνοιξε το. Ναι.
It was a moderate aortic stenosis.
Yes. Yeah. So you decided to give anyway mavacamten in these patients.
We first tried. First we gave him disopyramide because we wanted to see from where the symptoms was coming. With Rithmodan he felt better. So we thought that maybe we can give him a chance with mavacamten because he didn't want to have an early surgery to treat both.
And what about the ejection fraction? All of the patients had an ejection fraction greater than 70 or 75?
Yes, their ejection fraction was above 65%. They were normal and they didn't have they didn't reduce their ejection
so
fraction.
You did not observe a reduction of the ejection fraction? Okay. Yeah, I believe that, I'm going to talk about this now because I think we are really seeing a new class of drugs that will really help us in managing our patients. Yeah. Okay, shall I go on?
Yes, go on.
Okay, so Giorgos, first of all, I thank you very much, and I'm really sorry that I could not really sustain, your invitation and come directly to Thessaloniki. But I promise you that, in next time or maybe next year, let's say, I wish I could really come and see you because you really done a wonderful job there. So coming to the modern therapeutic strategies in hypertrophic obstructive cardiomyopathy, I would say that, basically we have four types of hypertrophic cardiomyopathy. Non-obstructive, you have then the classical left ventricular outflow obstruction, which was called once idiopathic hypertrophic subaortic stenosis, and then 25 years ago it was changed to hypertrophic obstructive cardiomyopathy. And then, basically through the MRI, we defined a new type, which is the mid-ventricular obstruction, where the outflow tract is almost always free, but the localization of the hypertrophy is in the mid-ventricle, at a site that Professor Ferrazzi, who was the most experienced now surgeon that we are having, I believe, expert in this kind of operations in Italy, he says at the equator of the ventricle. And then you have the last type, which is the apical, which is more typical for Asian people, but we also see many of them in the European and Caucasian. Now, how do we define the obstruction and the obstructive cardiomyopathy? By the gradient, the left ventricular outflow tract gradient, which must be greater than 50 millimeters of mercury, and you may either detect it at rest or after Valsalva or standing or with exercise echo. However, once you have detected that, you have to be clearly sure that it is SAM-related, that there is no subaortic membrane responsible for that, there is no aortic stenosis, and also at the same time, you have to be careful about the evaluation of the mitral valve. The mitral valve is now considered a strong and important component for creating the obstruction. So it is not in the hypertrophy at the site of the hypertrophy, but also the abnormality of the site, of the length of the leaflets, and of the associated papillary muscle abnormalities. As in a few patients, you may also observe mitral valve prolapse, which is responsible for the mitral regurgitation. So the mitral regurgitation does not depend on the obstruction, but above all from the mitral prolapse or mitral leaflet rupture. The minimum anterior septal thickness, which should be considered and is usually found, is 15 millimeters. But it has been clearly demonstrated that although you may have a lower hypertrophy, septal hypertrophy, you may still have, above all, with exercise, significant gradients and significant mitral regurgitation. So 15 millimeters is not a threshold, absolute threshold, but should be carefully considered the hypertrophy, which is not as big as I was mentioning, and that can create really symptoms and gradient and mitral regurgitation, above all under exercise. How do we manage these patients? Well, first of all, we have to see whether they claim that they have symptoms. And sometimes it is not easy to really believe these patients because the situation is so clearly abnormal that you wonder how they can claim they have no symptoms. And usually, if there is a fast heart rate, anyway, we used to give beta blockers in these cases. And I would say that at that time, we used to do a cardiopulmonary exercise test to understand what is their level of fitness and whether they really have symptoms at that time. Now, once you really have symptoms, which happens in the majority of the patients, then you have the classical possibility of using drugs, mostly beta blockers. And in our experience, we use Nadolol. And I believe that Nadolol is the most potent beta blockers, is a non-selective beta blockers. And we either use it alone or together with disopyramide, both at low dose, usually, sometimes at higher doses. And this is usually the treatment that we use. Very, very rarely we use calcium antagonist, almost never, I would say, only for people that are really intolerant for asthma or bronchoconstriction. However, the newcomer is the mavacamten, which you see in the European guidelines is considered as a recommendation of class 2A, while in the latest American Heart Association recommendations is considered as a class 1A. However, the other option, of course, is the septal reduction therapy, which in our experience, is only myectomy, the one in the field, because we experienced the septal ablation and, we had many failures and many problems. So we just go on with myectomy in case of failure of drug treatment. Now, why do, the newcomer, why the mavacamten? Because basically in the physiopathology of hypertrophic cardiomyopathy, we forgot that the sarcomeric dysfunction, mainly, at least, before the patients go into end stage, we observe hypercontractility with a higher ejection fraction than normal. And we didn't really care very much because, we are used to consider low ejection fraction, not high ejection fraction. But why is this happening? And this is happening because it was found from experiments that the interaction between myosin and actin depends on the number of heads of myosin that interact with actin. Usually about 50% of the heads of the myosin are at rest. I mean, they're off state, they do not interact. And they may be recruited, whenever we need. But instead, when you have a hypertrophic cardiomyopathy, you have many more myosin-actin cross bridges. So you have many more interactions between myosin heads and actin. And this, of course, takes you to hypercontractility, also an impaired relaxation, which happens really even in a greater way when you have troponin mutations. And then you have impaired compliance, and of course, you have stiffness. So this is what we all know and what we have observed, and we didn't really understand why this was happening, and now it is a little bit more clear. So what is the mavacamten about? Well, actually, it reduces the number of myosin-actin cross bridges. So it lowers the contractility, it lowers the power of the engine. So if I may use a comparison, I mean, you have a hypertrophic cardiomyopathy heart, which is like a Ferrari engine, and now, you lower it to a normal engine as we mostly use in our practice. So this is what happens. I mean, and when this was tested, not only in animals, but also with the first big trial, the Explorer trial, in patients, in a number of patients, you can see that really the gradients, both at rest and with the Valsalva maneuver, were really lowered in comparison with the ones that remain more or less stable, using placebo. But what was more surprising was the fact that the proBNP was incredibly lowered and maintained lower, throughout the study, and as well as the troponin. And I mean, in my experience, even in the patients that we did the myectomy, and the myectomy was perfectly done, I mean, there was a lowering of proBNP, but not really going back to normal like we see here. And above all, the myectomy didn't touch the troponin, the higher troponin levels. And the Explorer study then, when it was stopped, and then it was published, anyway, it was maintained and continued in most patients. The first study was 244, and 231 decided to go on with the study. They were continuously monitored throughout the study, and we now reached 180 weeks, so more or less three years and a half. And these are the results. The improvements, were maintained in over these 3.5 years of treatment. And as you can say here again, this is the gradient, and this is the Valsalva gradient. It was lowered immediately, very early, and then it was maintained throughout the study. And as well, this happened for the change in the class distribution, because you see that, almost none was in class 1. And then at the bottom of the study, after 180 weeks, about 2/3 of the patients were in class 1, and almost all of the remaining were in class 2. So really a benefit, on symptoms and functional capacity of the patients. At the same time, I mean, the average ejection fraction was lowered from the hypercontractility states, and it was maintained lower on average, of course, over most of these patients. However, the dose distribution, as you can see, it was more or less the same, but there was an increase in patients that had 5 milligrams of dosage. I mean, throughout, only another third of the patient had a greater level of 10 milligrams, only very few needed 15 milligrams, and about 1/4 could only use 2.5. Why that? Because there is this problem of the cytochrome CP19 that at that time it is important to genotype patients, and the EMA recommendations, both for Italy and, as far as I know, even for Greece, are the ones of trying to assess whether you are a low metabolizer, so that you don't incur in the worsening of ejection fraction. The worsening of ejection fraction was observed, in fact, and was observed in a minority of patients. Most of them, with an ejection fraction just lower than 50%, and a few of them even lower than 40%. But, with close monitoring, I mean, this kind of problem was solved because the drug was stopped, and it was, started again after the ejection fraction had increased again. Only a few patients really decided to stop treatment in this kind. So I believe that this is a fact that, we have to consider, And all cardiologists, whenever you use this drug, have to really monitor as close as possible this kind of patients. But above all, what was surprising was, at least to me, was the fact that at the Cleveland Clinic, they accepted to try to make a trial on patients that were eligible for septal reduction therapy. Actually, 90% of them were waiting for a myectomy, okay? And there were 112 patients. They were all, or almost all, in severely impaired, severely symptomatic in class third or fourth, and they were randomized either to MAVA or to placebo. And, with a great surprise, at least to me, really the majority of them improved. And they were no more eligible. Only 18% of those that took MAVA were no more eligible, while 77% remained eligible for septal reduction therapy. That means that they were still symptomatic, and they also had still their gradients. Moreover, there was an improvement in NIA class. In 27% of the patients on MAVA of two NIA classes, and 63% of one NIA class. And at the contrary, this did not really happen with placebo. And after 56 weeks, because the study was continued, most of the patients, both in the MAVA and both in the placebo, had the same outcome, in the sense that only a few of them had to proceed to SRT, so 2 out of 56, while on the other hand, some of them discontinued the study or proceeded to SRT in the placebo. And we now have the data of over 128 weeks of this study, which is called VALOR. And as you see here on the right side, you see that the blue line are the ones that took MAVA. The orange line is the one that were on placebo. And after 16 weeks, when there was a transition from placebo to MAVA, their gradients went down and remained down all throughout the 128 weeks, both at rest, Valsalva, or post-exercise. So the same results for them. And these were the results at 28 weeks. Most of the patients that were eligible for septal reduction therapy then were in class 1, so over half of them, and about 1/3, 29% to 30% were in class 2, and only a minority remained severely symptomatic at the end of the study. So really, and this is really, in a way, at least to me, something really incredible, that we could finally use a drug that really shows us that the MAVA is really so responsive, so efficacious in really lowering symptoms and, above all, reducing the gradients. So in conclusion, I would say that MAVA is a first-in-class inhibitor of cardiomyosin. There is also another one that will probably be approved later on next year, that has been shown also that could reduce gradients and improve symptoms. In 2022, FDA approved it, and many patients have been enrolled and are using it in the United States. So we shall soon have clear data on the, let's say, common practice use of mavacamten. In 2023, EMA approved the drug with some limitations, including the genotyping of the cytochrome. Italy has not yet approved it. I'm happy that Greece approved it and you could use it. We can only use it under compassionate study. However, I believe that we're now seeing really a brighter future, because we have drugs, that have demonstrated their long-term efficacy and safety. And this is really now well established from many studies. However, there are some problems. One is the high cost. We do hope that the cost will lower in the future, because this really is a big problem. Above all, is one of the reasons probably that why Italy yet has not approved it. However, for cardiologists, there is a need for patient selection and close monitoring for long-term follow-up of these patients. Thank you very much.
Thank you, Franco. Despina is going to make some comments on your talk and probably some questions.
Okay, Professor Cecchi, that was a great presentation, very fresh and inspiring for all of us. I would like to ask you a question. There is a trial that that started. I think it started recruiting on April 24 about the mavacamten in the adolescents between 12 and 17 years old with symptomatic obstructive hypertrophic cardiomyopathy. And do you think that this trial will give us information about this very important period of adolescence for hypertrophic cardiomyopathy, because it's the period that the phenotype progresses, and so to give us information about the effect of the drug in the natural history of the disease, maybe.
I hope so. I hope so. I believe that, the question is absolutely correct. And I believe that we still need to collect data. So one of the problems that we might incur, and I hope that you, with this beautiful network that you have created in Greece, you can collect data on all the patients. That's what we are doing now in Italy. So the question is, and the answer that I might give you is, try to really have a database on all patients that use MAVA to understand whether, really we can see, an event or, an improvement, a long-term improvement, like it has been shown now by these studies. Now we are in current practice, so we have to be careful in selecting patients. And I hope that this will really help us for adolescents. As you probably know, this is the most dangerous time for them. We have no data about the arrhythmias so far, unless, we're going to see the progression of the disease, as the arrhythmic events sometimes happen after the disease has progressed and has formed some fibrosis. So if you prevent and you block the development, or at least you slow the development of the hypertrophy, in younger patients, I believe that this will help us in their natural history and their outcome.
There is a trial that is starting in Greece, and it's called GRECO with mavacamten. It's an observational study where we are only record the information about the drug and see about the health status of the patient and the quality of life. So we will have some data from this trial also, the GRECO study.
Yeah, this is the most important fact, really. That's what we also do. We now have in Italy over 400, more or less 400 patients that are now on the drug, and they have started on average 6 months ago. So this means that probably in the next few years, we shall have data on a larger database than the one that I've shown you in the Explorer. So this will really be current practice problem. And this is, spread all over Italy, of course, not only in a few centers, in a few selected centers. So we really test also what will be the outcome, and in small centers, small cardiology centers that will have only a few patients.
Thank you very much.
So, Franco, the drug seems to be effective with no complications.
I can't hear you, Yorgos. Maybe you have to open.
The drug seems to be effective with no complications. The main question is how long we have to give this drug. 20 years, 30 years, 40 years, like what we done with beta blockers, probably. That's my question.
Well, yes, but let's suppose, or let's dream for a moment. I mean, I will give you a lecture about the gene therapy later. So maybe that if we get 10 years, I mean, of good health in these patients and, few symptoms, that maybe in 10 years or 15 years, I hope that by 2030 or 2040, I mean, we'll be able to test this new type of treatment. I believe this is one of the really future new aspects in all kinds of diseases, not only in hypertrophic cardiomyopathy, but also on other cardiomyopathies. So maybe it's a dream, but maybe, it will become a reality. So we don't have really to complain that maybe we have to give this drug forever. The problem may be the cost, because Georgos, I mean, after all, we give beta blockers for all lifelong. So, and maybe we have to give both beta blockers and MAVA or something else.
Now, have any question from the audience? The elected president have you any question? No? Have you any questions from the audience? Okay. Angelos, would you like to ask something? It's a brief comment and to finish.
Franco, hello. This is Angelos Rigopoulos.
Hello.
I would like to ask you just to make a comment on the future of septal reduction therapy in the era of mavacamten and other myosin inhibitors.
Well, actually, I mean, we really have a big experience now with the septal reduction therapy, both on alcohol ablation, which we did in the early 2000s, I mean, until 2005, 2006, before we started to do myectomies. And actually, I believe that about 10% of our patients that, are still eligible for surgery. The problem will be the surgeons, because the surgeons must be experienced in dealing with this kind of hearts. And that will be a big problem. So maybe we suppose that in Italy, it might be, maybe 1 or 2 surgeons might be enough. Because you have some abnormalities of the mitral valve apparatus that really, cannot be solved by the drugs. I mean, you really have to clear them. So even if we are diagnosing these patients earlier in life, so we are not exposing them to long-term stress and mitral annular calcification and so on. But nevertheless, you have really, like a congenital heart disease at the mitral valve level. So, and if you cannot cure that, with drugs. You have to go there by your hands and knife.
Okay, but you believe that the expertise will stay on? I mean, if myosin inhibitors are so successful, then there will be less and less patients who will need surgery after all.
But I believe that, for instance, in the United States, 300 million people, I mean, you will have always Cleveland Clinic and Mayo Clinic. So they will, receive patients from all over the world. Maybe even we Europeans or Italians, I mean, 60 million people, maybe we still have the need of having 1, 2 experienced surgeons. For sure, we cannot have as many as, there are now, although most patients are referred to the most experienced one. But there will still be room for patients in this sense. That's my belief. Maybe this will not be confirmed. But maybe, to me, there is a number of patients. Also, we don't know very much about the effect of mavacamten in mid-ventricular obstruction. I believe that this will be helpful, but it might not be helpful. We have patients with several fibromuscular branches that go from the apex to the base of the heart. And unless you clear that, and unless you detach them, one by one, you cannot clear the mid-ventricle. So I believe that there will be still room.
Okay, thank you.
Okay. Thank you all for the attendance. Now we move on the next round table, imaging in cardiomyopathies.